So now let's get started. I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation's educational webinar series, and I'm also a patient living with MPA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we'd like to thank our sponsor, AstraZeneca, for supporting this webinar today. Today's webinar is benralizumab, also known as Fasenra, and mepolizumab, also known as Nucala, approved therapies for EGPA, and we're with Dr. Peter Merkel today and the patient voice of Jennifer Gordon. After we finish this webinar today, there will be a recorded version of the Vasculitis Foundation's YouTube channel, and everyone who's registered will receive an email with a link to it as soon as it's available. I'd like to begin by introducing our guest speakers today. Dr. Peter Merkel, Dr. Peter Merkel is a rheumatologist and an internationally recognized expert in clinical care and research in all types of vasculitis. He's the co-principal investigator of the Vasculitis Patient-Powered Research Network and the principal investigator of the Vasculitis Clinical Research Consortium. He's a professor of medicine and epidemiology and director of the Penn Vasculitis Center and the chief of Division of Rheumatology at the University of Pennsylvania School of Medicine. He's also been the principal investigator on multiple NIH, FDA, and PCORI research grants that focus on clinical and translational investigation in vasculitis. And he helps direct international clinical trials in multiple forms of vasculitis and has over 400 medical publications. He received his medical training at Yale, Penn, and Harvard. And I'd also like to introduce Jennifer Gordon, who is living with eosinophilic granulomatosis with polyangiitis, known as EGPA, a form of ANCA-associated vasculitis. She currently serves as the co-lead patient partner in the EGPA registry, and she hosts the EGPA Cafe Zoom chat through the Vasculitis Foundation. She holds a PhD in pathology and has spent the last 30 years working as an NIH-funded biomedical researcher studying neurological disorders and infectious diseases. You can find her blog online at vasculities.com or follow her on X, formerly known as Twitter, as @vasculities. Okay, welcome, Dr. Merkel and Jen. We're so happy to have you here with us today.
Great to be here.
And I think what we'll do is we will start with the very first poll question today. Let's see if I can bring that up, and that will give us an idea about who's with us today. All right, ending the poll now so that Dr. Merkel can see the results. Looks like we have 88% patients with us today, and some caregivers, some industry partners, and other. Okay, if Dr. Merkel, I think it would be great if you would share your screen and start your presentation.
I think you should be seeing it now.
So
first of all, thank you I'm going to time myself here. Thank you very much. Hope you all hear me for inviting me to be part of another Vasculitis Foundation webinar. I've been a proud member and participant in the Vasculitis Foundation for several decades. And this is your Vasculitis Foundation and ours as well, everybody's. And so this is great that we have an opportunity to talk about important topics to the vasculitis research community. I'm going to talk today about an update on benralizumab and mepolizumab, which are two approved therapies, meaning that you can actually approved by the United States Food and Drug Administration and some similar groups around the world for eosinophilic granulomatosis with polyangiitis. I have lots of logos because I do lots of stuff with everybody. And I also want to tell you about disclosures. I work with a lot of drug companies and in order to help develop drugs for vasculitis. It's great to see so many companies interested, and we've been able to get some of these approved. I also take various research grants as well. And I want to particularly point out that I've been a consultant for both AstraZeneca and GlaxoSmithKline, GSK, and AZ. And these are the companies that actually make the drugs we're talking about today, or at least focusing on. I'm going to be mostly using the generic terms because I prefer to do that as a physician and as a scientist. You may know them by their brand names, though. So the lecture will mainly use the generic terms. Benralizumab is the generic term for Fasenra. Mepolizumab is the generic term for Nucala, and Registry is the generic term for Sinquare, but that's not approved and not used very much at all in patients with EGPA. So Benra is Fasenra and Mepo is Nucala. So we're going to go back to another poll question because it was interesting to see that the vast majority of our audience are patients. I'm assuming it's patients with EGPA, but you may have other interests. And the question is, and Kathy's going to put up the next question, are you currently taking any anti-IL-5 drugs, any of these three, for your asthma or EGPA of any sort?
Okay, I think we've got most of everybody has answered. I'll share the results with you.
Okay, so of the people who answered, the majority are taking these drugs. A few others, ones that they've taken in the past, and some have not taken it. And that's about kind of distribution I would expect. And again, it really may depend on where you live and where the state of your disease is, but that's very helpful. Okay, so let's get into the topic in more depth. This is our usual guide for all the different types of vasculitis. Is based on a nomenclature that we came up with several years ago. A group of us, I've added some more on the upper left to fill out everything. And what we have is, what we're going to talk about today is ANCA-associated vasculitis. Again, it can be confusing because there are three types, MPA, GPA, and EGPA, and they are similar. But we're talking about EGP today, EGPA, or eosinophilic granulomatosis with polyangiitis. Long ago, it's now quite a few years, we called it Church-Strauss, but we really like to use the term EGPA. So what is this? Well, it's a type of vasculitis, and I'm going over it because some of you may be very new to the disease or are caring for patients or partners of patients. This is a type of vasculitis characterized by eosinophilia. So eosinophils are a particular type of white blood cell that circulate in all of us, and they can often help us fight certain infections, but they're very much involved in allergy and allergic reactions and things like inflammation. And eosinophilia has to be present for everybody with EGPA. That's how it gets its name. Asthma is present in 90% or more of patients. Pulmonary infiltrates, pneumonia-like situation, but non-infectious, heart disease, neurologic disease, skin disease, and other things. ANCA, this blood test, which is very common in most patients with the other two forms of ANCA-associated vasculitis, is present in about 30–40% of patients with EGPA. So that's another difference with GPA and MPA. And these diseases, EGPA overlaps with GPA, but it also overlaps with other forms of what we call hypereosinophilic syndrome, which is high eosinophils and various disease issues. So it's a funny disease, not funny when you have it, but peculiar, and it's relatively rare unless you have it. There's a lot of overlap with these other diseases, and the diagnosis can be tricky. The problems can be quite serious. They can range from annoying to organ and life-threatening. Asthma is a huge problem, as is the upper airway, and we'll talk more about that. You can get atopy, which is sort of an allergic reaction and skin issues. You can get nasal polyps, which can be quite annoying to patients. This is a very nice long list, not nice, but very long list of features of ANCA-associated vasculitis. And all of these things can happen in patients with EGPA. But the most common things that happen and are not necessarily part of the problems with GPA is eosinophilia. Asthma is present in 90+% of patients. Nasal polyps is common. And then eosinophils go to all sorts of places and cause trouble: pneumonia, skin lesions, neurologic disease, GI, and cardiomyopathy, which is a cardiac disease when infiltrating with eosinophils can cause heart problems, is relatively common in EGPA. So how common are some of these things in the real world? Well, this is a report from our Vasculitis Clinical Research Consortium that we reported on a very large number, 354 patients that we studied for years. This is a huge cohort of patients. We actually have it even larger now, and some of you are probably participating in this research. And this is the kind of data we can only get from patients. And what we found is when you look at patients at diagnosis or several years later, a lot of features are very common. Many people have had a variety of constitutional symptoms, general symptoms like weight loss and fatigue, very, very common. Later, they have weight gain with the prednisone. Ear, nose, and throat issues are in 80+% of patients, whether it be sinus or nasal polyps or both, or runny nose and crusty nose. Lung disease is present in almost all patients, especially asthma, but other features as well. And I'm highlighting asthma here. Skin manifestations are cutaneous, common, not in everybody, but a third of patients get it, and there are all sorts of different skin lesions they get. Neurologic disease is unfortunately quite common and can be very problematic. It's painful and or causes some disability when you can't move certain things. Cardiac disease is present and can cause serious problems, more often early in the disease, but sometimes later. Gastrointestinal disease is not that common, but problematic. Same with kidney disease. Why do I mention all these bad things? Because I think you need to know the spectrum. And one of the things we're going to talk about is, do these new drugs work for all of these different manifestations? Now, what's interesting is the average patient has 5.5 of these different things happening to them when they come in, when they first were diagnosed, and then they gain another 1 or 2 later, sometimes 3 or 4 different ones later in the course of their disease. So it's a disease we need to take very seriously. Many things can happen. It ranges from mild to very serious and back and forth. I don't like to hold back. What happens over time is that patients get what we call damage, which is chronic issues that may not be reversible. This is again from the same patients, so we have a lot of data to go on. Chronic asthma is the biggest problem, recurrent need for treatment for asthma. Sinus disease as well. I skipped a few because I'm concentrating on those symptoms, those problems that the drugs we're talking about today are been shown to be helpful for, in addition to nasal crusting and blockage. So, how do we treat this disease? I'm going to give you an overview, and then we're going to go into some detail about the use of these new drugs that block IL-5, relatively new. Treatment may include glucocorticoids only. Glucocorticoids, you may know them as steroids, prednisone, prednisolone, methylprednisolone, Solumedrol, things like that. These drugs, we all know that we hate, right? So we have a love-hate relationship with these drugs. We love to hate them because they cause lots of problems, but they're incredibly effective. They work quickly and they work well to suppress inflammation and to reverse problems with asthma. But of course, they cause a lot of side effects, including to your eyes and weight gain and bone changes and diabetes and infections and many other problems. As I like to say, they're the best drugs we have and they're the worst drugs we have. And we work very hard to get people off of glucocorticoids, and you work very hard to go to the lowest dose possible, with 0 being a very nice goal. But we use a lot of glucocorticoids still to treat EGPA. You got to treat the asthma. I'm going to have a lot more to say about that. It's not really separate. It's part of the disease. It's common that patients are on low dose glucocorticoids, so prednisone at 5 milligrams, 7.5 or 10 milligrams a day chronically. That causes some problems, and we'd like to try to get rid of those too. This class of drugs, this group of drugs we're talking about today or focusing on today, the anti-IL-5 drugs, they're now a standard part of treatment, and I'll explain to you why. But for more severe disease, we still use a drug called cyclophosphamide or Cytoxan, and we use rituximab. It goes by several names, and they use them frequently for patients with more severe disease or more problems. We also combine drugs, but we have not that clear what to do. Some of you may be on azathioprine, methotrexate, mycophenolate. It's not exactly clear how effective those are, and we don't exactly know how good all of our drugs are to keep people in remission over time, but we're learning. I wanted to highlight, at least in those areas, including the United States, where we have access to these new drugs, they are now very common. So looking at our guidelines, of which I was part of, and These were the American College of Rheumatology Vasculitis Foundation guidelines. So the Vasculitis Foundation helped sponsor and support these. These were guidelines for the treatment of vasculitis, and this, in terms, and this conversation is AAV, including EGPA. So here gets complicated, and we have lots of arrows, but you can see that if you have non-severe disease, so you don't have heart or neurologic disease, but you still could be moderately serious, but less than terribly serious, we will often start with glucocorticoids plus mepolizumab, which is the Nucala drug that we're going to talk about. This, and then there are lots of other options. And you can see it comes up either early or late. But I will now tell you that benralizumab, Fasenra drug, is also appropriate to consider as an alternative to mepolizumab. Why is it not on the chart? Because the chart was published in 2021. And the data on benralizumab came out, and I'll show you when it came out this year. For more severe disease, we do pulse glucocorticoids, high dose, and we often use cyclophosphamide or rituximab, and then we do something else later. But the question is, what about these new drugs? Would they be useful in more serious disease? And the answer is a definite maybe. We don't know yet. We need more research on that. We are hopeful of that, and many of us are using them earlier in the course of disease when you first present, more likely, but we don't have the data to support that fully, and we need those data. What we do know is that we can probably use these drugs in combination with other drugs, but this is an area of active interest from patients and physicians and nurses. So when you look at it as a whole, it looks complicated, but what's nice is we actually have data that is guiding our decisions. And that's something that is not always the case with vasculitis. We need more trials in EGPA for sure. This is a difficult disease to study, but we've been successful in doing it, thanks to patients who volunteer to be part of research. Although they're not detailed in the guidelines, the importance of proper treatment of asthma and sinusitis and upper airway disease, so we have upper airway disease and lower airway disease, cannot be overemphasized. It is incredibly important. It's a crucial aspect of treatment. So we're going to ask another poll question. Is asthma and or sinus or nasal disease a significant problem of your EGPA, a significant part?
Completed the poll. We'll wait a little bit longer to give you a chance.
Come on, people, let's vote. It's a privilege to be able to vote. Not everybody's a patient.
All right, we're at about 84%. So I'm going to end the poll and share your.
So interestingly, the one way to look at it is 80% of the people who answered have asthma and or sinus nasal disease. That's about right. That's what you would expect in this disease. You usually expect even more, actually. So it tells you that this is a big problem. So how do we treat asthma? I am not an asthma specialist per se. We often partner with pulmonologists or allergist, but I do a lot of treatment for asthma, or I co-treat because it's so common in EGPA. And this is a basic overview of what you treat for asthma, and it should ring true to the patients on the call. So we use a lot of glucocorticoids or steroids. We really don't want to, but they work very quickly. If you can't breathe and you're in the emergency room, we want to give you something to help move that along. So a lot of prednisone, intravenous methylprednisolone or Solumedrol brand. Inhaled drugs are common. The inhalers, the puffers, especially in the lungs or in the nose and sinuses, such as fluticasone or budesonide. There's actually quite a number of them, and they go by all. The trouble with inhalers is there's so many different ones. They have different drugs, different combinations, and different brands. They can get confusing, and then your insurance company changes which one you can get, and then the manufacturers change them. But these are very commonly used. The inhalers include the beta, in addition to the glucocorticoid inhalers, the beta agonists, which open up the airways. This is the so-called rescue inhalers, albuterol, but also longer acting ones, which are called LABAs, which prevent you from needing to use your rescue all the time. These are incredibly important. There's another group called anticholinergics. We use those sometimes. And then there's combination where you combine the glucocorticoids up here, plus or minus the beta agonist, et cetera. I should have included the inhalers down below with the glucocorticoids here as well. Combinations, especially of a glucocorticoid or steroid inhaler plus a beta agonist, very common. Then up on the upper right, you'll see you also want to treat if you have allergies. If you have seasonal allergies or pet allergies or food allergies, you're going to want to treat those with antihistamines, something called leukotriene inhibitors, mast cell stabilizers, that's cromolyn. We don't use a lot of those. Some people get allergy shots. That may be important, though we're doing less of those than we used to. And of course, you're going to avoid triggers. Unfortunately, if you're allergic to cats, you probably shouldn't have a cat in your house if it causes you to get asthma, things like that. And then today's targeted therapies, so-called biologics. Biologic is just a way that drugs are made, but these are the fancy new drugs we've been really using a lot of in rheumatology and immunology for 20 plus years. Omalizumab, it's called Xolair, is an anti-IgE. This is a drug that is useful for patients with asthma. It's intravenous. It's useful for a subset of patients. All of these have some good and some bad uses. Dupilumab or Dupixent is a complicated new biologic. It's used, it's injectable, self-injected. It's useful for asthma. It may be useful for polyps and other things as well. Tezepelumab is relatively new. It's also being used for these indications, and you might especially get that from a pulmonologist. And the drugs we're talking about today are the anti-IL-5 therapies and the three I keep mentioning, but especially the first two, because the last one's not approved for use in EGPA, and we don't have data on its use. So that's what we're going to focus on today. But I wanted to give you some background so you know it's not that we use these drugs and not necessarily anything else. It's in the context of everything that's right for you. So let me ask a question. How many people here are stuck on prednisone to control your EGPA? And let's ask the question. And this is it. Yes, I'm on less than 5 milligrams a day, or less than or equal to, let's say, 5 or less. Yes, I'm on 6 to 10. Yes, I'm on 11 to 20. Yes, I'm on more. No. So we're getting the votes in.
Looks like we've got what we're going to get. So I'll
Okay, the
end.
80%. I think we have some other guests who aren't voting because they're not patients. So you'll see that, again, more than half, slightly more than half of patients are on some dose of prednisone. That's now. If you asked how many people had previously been on it or stuck on it for a while before, it would be even higher. And what you can see is, yes, people are on 5 or less, but there's plenty of people who are stuck on higher doses. And my bet is if we asked a different question, which is, okay, you may not be stuck in this dose, but how many of you get it 1 or 2 or 3 times a year for a couple of weeks? The numbers would go even higher. And that's the problem, is that we still are using more, you could argue, any degree of prednisone. It's not, it changes. So 10 is worse than 5 and 30 is much worse than 10. So it's not perfect formula, but there's a lot of use of prednisone or similar drugs in EGPA. So why are we interested in IL-5? What is this thing? So interleukin is a fancy name for a series of chemicals that circulate in the body. IL-5 or interleukin-5, you can see here, it does a lot of things, but for our purposes, here's it, star of the show here. It works with eosinophils. It makes eosinophils, which is a type of white blood cell, it makes them excited. It makes them active. And then they go and do things. That's good if you're fighting against a parasite, which it does help. It's not good if it causes inflammation in your lungs or in your skin or in somewhere else. And so that's the balance here. And what happens in EGPA is there's a lot of IL-5 floating around, and it causes a lot of problems because it makes the eosinophils very active and involved in inflammation. And you can see it does it in the eosinophils move around. The IL-5 goes to the bone marrow and say, make some more eosinophils. Then they go into the blood, and then they go to your lung and cause problems. And you can see that there's lots of different interaction. One of the things that I like to talk to our trainees about is this is a figure about just a small part of the immune system. The The immune system is incredibly complicated. And if you interrupt one part, something else happens. But the idea here is that we're interfering with IL-5. So how do we do that? What we call mechanism of action, which is like, how do the drugs work? Well, here we have an eosinophil over here, the bottom left, and then here's another cell that gets involved, another type of white blood cell. These drugs, and I especially concentrate on mepolizumab because that's the one that's available, they bind to IL-5. So IL-5 is this little circle there, it's all over the place. And this is an antibody. It attaches to the IL-5 and helps it get rid of it in the body. So mepolizumab and benralizumab directly bind to IL-5 and helps eliminate it from the body. And if you have less IL-5 around, you have less badness happen with the eosinophils and other things. Actually, IL-5 does other things besides the eosinophil. On the other hand, benralizumab down here is a different antibody, and it binds the receptor, which is it's a structure on the cell, on the surface of the cell that interferes with IL-5. For your purposes, it's all about IL-5 doing stuff to eosinophils. But what I'm trying to show you is that the drugs do different things. They end up affecting how eosinophils act in different ways. They are, however, all related by interfering with IL-5. So I hope that wasn't confusing. It's important to know they work differently. So they work differently. Benralizumab and mepolizumab both block IL-5 and interfere with the function of eosinophils as white blood cell that causes problems in similar but not exactly the same ways. How important are these differences? That's an interesting question, and we're going to try to look at that in terms of the data we see here. So why are we so excited? Why are we using these drugs? Well, this is a study I was part of with Mike Wexler, a group of us. It's sort of the same people each time who do all these international studies. There's a gang of us, and this was an important study we did called the MIRRA study, and this was mepolizumab or placebo for eosinophilic granulomatosis with polyangiitis. It was important enough that it was published in the New England Journal of Medicine. What did we find? Well, first of all, what was the study? It was a randomized, double-blind, placebo-controlled clinical trial. So what does that mean? Well, randomized means that the computer says you're going to go into group A or group B. Double-blind means the patient doesn't know what he or she is on. The doctor doesn't know what the patient's on. If we need to know, there's a way of safety doing it, but we don't need to know. And most of the time, and it's placebo-controlled. So patients either got mepolizumab, active drug, or placebo, which is a fake drug. And patients were enrolled who had EGPA and relapsing refractory, meaning they couldn't get their treatment properly done. They weren't able to get control, even on glucocorticoids. However, and then they got either mepolizumab, 300 milligrams, 3 shots per month, self-administered. They give a shot, or the nurse can give it to you, but now patients just give it themselves for the most part, or placebo shots. We followed them for 1 year, and the goal was to get off glucocorticoids and not relapse. So what did we find? Well, in red, you'll see those are the patients who are on mepolizumab. Up is good. Up are the percentage of patients in remission. And you could see that after we started, it's weeks, it's about 1 year to the dotted line. Over that year, in blue below, very few patients were able to stay in remission. They had to be, and remission was 4 milligrams or less of prednisone. Remission meaning no active disease, no, your EGPA was not active, including asthma. And on the other hand, the patients with MEPO were much more likely to stay in remission. However, still it was in the 30 to 40% range. So, but they generally did better. Is that good enough to make a difference? It really is a big difference clinically, and it was very helpful to patients. Another way to look at it is how many people had relapses, because people went into remission when they started the trial because we gave them more prednisone. So we squashed the disease with prednisone, started withdrawing it, and then you can see that the patients who got the drug in red, this time down is better, were more likely to stay in remission. Now, we did another analysis looking at the data later. We asked them different questions after the trial was done. And what we tried to figure out is, okay, let's get a little more detailed. And the numbers, it's a pretty big study for EGPA, but even so, the numbers get small. And what we tried to figure out is, okay, how good was this in addition to remission, not remission? What about ability to come off glucocorticoids and not have remission? And I want to highlight one particular point here, which is in the lower left circles on each of these things, the number of patients who were able to reduce their glucocorticoid dose. And you can see that it was overall the circle, when you add up, for example, this number plus this number is 14 out of 68 in placebo. That's not so great. 49 out of 68 in the mepolizumab who got the Nucala did better. That is good. And another way to look at it is when we look at a variety of outcomes, patients who got the drug were more likely to have a clinical benefit, including cutting their prednisone dose in half or greater or not having relapses. Perfect? No. Good? Yes. Very good? We think so. Much better success. So the summary of this trial, the MIRRA trial, demonstrated that for EGPA, and I would mention this drug was out for years before that for asthma, certain types of asthma. So for EGPA, the use of mepolizumab in higher doses than asthma versus placebo improves the chances of patients being in remission, having fewer relapses, and reducing their dose of glucocorticoids. The safety profile of mepolizumab, 300 milligrams a month, was excellent. I didn't show you that, but it was excellent. But a couple of caveats. The ability of mepolizumab to treat severe manifestations was not studied. So we didn't have people come in with heart disease or neurologic disease, for example. Many patients did not achieve remission. Time under treatment was relatively short. It was 1 year. 1 year is good, but you don't want to be treated for 1 year. You want to be treated for the rest of your life. So what if we used a different type of IL-5? Well, I just showed you there's another type to try. What about benralizumab? So this is the MANDARA trial, and Dr. Wexler and I ran this trial, and again, it was published in the New England Journal. And this was somewhat different, but it was very much based on the MIRRA design. So what was the MANDARA trial? This was benralizumab versus mepolizumab. So this is different. The other one had placebo. This one has no placebo. One drug versus another drug, what we call active comparator. So that's exciting. If you enroll in this trial, you know you're going to get a drug that we think is going to help. I would mention that this trial was conducted mostly during the pandemic, COVID-19, which created all sorts of interesting challenges internationally, but the trial was done. It was a randomized double-blind trial. Again, we didn't know which drug patients were on, neither did the patients. It compared these two different drugs that work slightly differently, and they enrolled patients exactly the same as in the MIRRA trial. And there's a reason it was purposely done that way, exactly the same. And patients could receive either benralizumab, which happened to be at a dose of 30 milligrams a month, versus mepo at 300 a month. Or placebo is not correct. I'm going to actually change that right now so my slide's perfectly done. Look at that, on the fly. So, almost exactly the same design as MIRRA, except instead of placebo, some patients got benralizumab. So it's an interesting design. What did we find? Well, again, up is good. This is the percentage of patients who got a relapse, or the time to relapse. This is how long it took to relapse. What you can see is there was absolutely no difference between the two drugs. They were almost exactly the same. That is actually what we proposed. That's what we thought would happen, which is that the two drugs would be the same. Why did we do that? Because it's hard to show superiority because we think the drugs are pretty good. So by showing that both the same, it gives you another option. But there may be a few subtle differences. So what you can see is that the patients overall, over a year, about 30% of them had a relapse, and took time to get to their first relapse. More of them had relapses later. Well, you say that sounds better than during the MIRRA trial. It was, and we're not exactly sure why, but we think it's because people were actually at home more with the pandemic, and they weren't getting sick. They weren't getting things that may have stimulated their disease, and it was a different time when different patients were enrolled. When we looked a little more detail at the two groups, the darker color is the benralizumab, the lighter color is the mepolizumab. Again, that's Fasenra and Nucala. What you can see is it was mostly the same. On the left, you can see ability to cut your glucocorticoid in half, about the same. The ability on the right to go to 4 milligrams or less, the same. In the middle, though, there was a difference. 41% versus 26% of patients were able to get completely off of prednisone. Now, that means that the majority of patients were not able to come completely off of prednisone. So I think the glass is half full here, because this is great. These are patients who have a lot of trouble coming off prednisone. Does this mean benra is better than mepo for this? It did show it here. We'd like to see that in a larger study as well. But this was an advantage of benra versus mepo for some patients. This is interesting. This is how well do the eosinophils go away? So the idea of this drug is to get the eosinophil level down. You can see with the lighter color that patients very, very, very quickly, within a week, the eosinophils go down to a very low level. Just trust me, that's a low level. They go down even lower in the mepolizumab, in the benralizumab arm, people who got the benralizumab, and they stay down. And we think this is how the drug is working, and so down is good. And so there was a bit of a difference, more reduction in eosinophils with the benralizumab. So summary. So the MANDARA trial demonstrated for EGPA, benralizumab, and mepolizumab were equally effective. They were the same versus placebo for the main outcome, to help patients achieve remission, have fewer relapses, and reduce their dose of glucocorticoids. The safety profiles of both drugs were excellent. That means they really didn't cause significant side effects for most patients. We were very pleased with the safety, but we already knew these drugs were safe because they were used in asthma, although these doses are higher. Caveat is that the ability of benra to treat severe manifestations was not studied. Many patients did not achieve remission, and the time under treatment was short, although we now have another year of data following patients, and it looks pretty good. I'll show you that later. So I just want to repeat, we now have is now a standard to use IL-5 a lot. How much? Well, a lot of patients with EGPA are using these drugs. When these drugs become available to treat in other countries, their use goes way up. Should these treatments be used earlier in EGPA and or for severe manifestations? That's a great question. This is a happy question. This means we have a drug we think is effective. Can we use it even more patients for more reasons? This is some data from, again, our VCRC registry of patients that are followed over time. And this is a very quick analysis that we did. We haven't published this quite yet. This is looking at different drugs and how they're used over different, almost not decades, but in various 5-year periods. And as you go to the right on each of these graphs, it's later and later. The drug, this wasn't even released until 2017. And so you can see once this drug mepolizumab was reduced, the use of it went way up. And it's now even higher than that. So it shows you that we're using them and people are staying on them. So let's compare these two drugs. We have a trial that compares. One targets the IL-5 receptor, one directly targets IL-5. Both have been available for asthma for several years. Benralizumab was approved this year to treat EGPA, while mepolizumab has been out since 2017 to treat EGPA, so more experience there. Benralizumab is 1 shot per month. Mepolizumab is 3 shots per month. It's just how it's dosed, although you get them all at once. Both drugs help reduce the dose of prednisone. It's possible that benra may more likely to get to 0. We need to confirm that. They both have excellent safety data, and they're both pretty expensive, at least in the United States, which is an issue because I want to talk to you about how you get it. So here are some tips for prescribing benralizumab or mepolizumab for EGPA, or tips for how you can get this drug prescribed for you if you need it. These drugs are approved by the United States Food and Drug Administration for EGPA and in some other countries. Why is that important? It's incredibly important because if the drugs are approved, your insurance company should pay for them. And they tend to not want to pay for expensive drugs that are not approved. The doses of these drugs are different for EGPA than for asthma. That's important to know because if your doctor isn't that familiar with the drugs, he or she may not, or your nurse practitioner, whoever, may not prescribe the drug properly, or they may not have it in their computer systems. You want to make sure you get the EGPA dosing. The drugs are expensive, so there may be copay issues that you may have to face. The manufacturers all have programs to assist patients. It differs by various insurance companies and states. By the way, getting sick is also expensive in many ways. So you got to balance this. Getting in the hospital is incredibly expensive. So we balance this in society about drugs versus costs. Insurance companies may resist approving these drugs. You know what I say? You need to fight for them. If you and your doctor together feel that it's the right treatment for you, then you need to fight to get these drugs. And we've been very successful. It really does depend on where you live and what the insurance rules are wherever you live across the country and what insurance practice you have. But you should be able to get these drugs if you have a diagnosis of EGPA. Different patients may do better on one or the other drug. Switching is possible. I think we'll talk about that. These drugs can be used in combination with other drugs. I'm going to spend a little more. I think we'll talk about that with Dr. Gordon together, but we use them regularly with other drugs. So what do we still need to do in EGPA? We still need to get people off glucocorticoids. We need to avoid some of our other drugs if we can help it, and especially for women during childbearing years. We need to reduce the infections that can occur because of the treatments we use. We need to determine the efficacy of some of our irregular drugs. Are they worth continuing to use? We need to define the treatment of severe disease. Should we be using these new drugs? Which drugs do we use? What combination? We need to understand adrenal function in patients with long-term glucocorticoids. The adrenal gland goes to sleep a little bit when you take a lot of glucocorticoids, prednisone. Does it wake up enough? We need to understand that better. We need to describe the disease course using the updated treatment regimen. So now we have new treatments. What does that look like? And we need to prevent relapse. That's the biggest issue, and especially asthma, but not just asthma. And we need to be able to treat flares short-term and quickly. And some patients just have really difficult disease to treat. We need to be able to treat them as well. And I always like to end, let's cure this disease. Let's cure all our diseases, but we should be able to cure this disease. So I'm going to stop there and happy to take questions. I hope that was helpful. Shorter than 40 minutes, and happy to take questions. Hope that was helpful.
That was great, Dr. Merkel. Thank you so much. And we do have a few questions from our patients, so I'm going to ask you a few, but I'm going to start with the first one. Is there a difference between doses of anti-IL-5 drugs for asthma and for EGPA?
So as I just mentioned, that is a good question. Yes, the difference is for mepolizumab or Nucala, the dose for asthma is 100 milligrams per month for one shot. What we tested in the trial for EGPA was 300 milligrams or 3 shots a month, all usually at once. Why can't you put it all in one big thing? Because they don't. However, some patients start experimenting, and sometimes people are doing well on 300, we might try 200, might try 100. The drugs are so really well tolerated and safe that we tend not to do that too much. Sometimes patients come to us because their asthma doctors give them 100, and then we'll raise it to 300. So it depends on where you're at and what you need. For benralizumab or Fasenra, you usually get 30 milligrams, which is one shot. The fact that it's 30 versus 300 and 100, the numbers, they're different drugs, so you can't compare the doses, but you get one shot. Usually it's once a month for a couple of months, and then every other month for asthma, but in EGPA, it's every month. So again, you got to be careful about that.
Understood. Thank you. And we had one patient that asked about if, for instance, if Nucala doesn't work well, would Fasenra be the next option? So what about switching anti-IL-5 drugs?
Well, that is an area of great interest and research. First of all, we have some data that will come out on that in the MANDARA trial. Everybody got one or the other drug, right? They got Benra or Mepo. After a year, they had the option of switching from Mepo to Benra, not the other way around because it was sponsored by AstraZeneca. And we actually have a year of data that we'll be reporting on for that as well, which is interesting. But we're interested in following patients on this. In the real world, we are switching. Now, what's interesting, in the United States, almost all patients with EGPA who are on an IL-5 inhibitor are on Mepo because it was approved, and so we can get it paid for. So now we may have patients who are going to switch. And in other countries, Benra was more commonly used because it was available, and those patients may switch. So who should switch? I think that's a discussion between you and your provider. Are you at a level that you're comfortable with? Maybe you're on 5 milligrams of prednisone and you're doing great and your bones are good and you're fine. It's like, I have never felt this good. I don't want to change. Or maybe you keep getting 10 milligrams of prednisone, or maybe you keep flaring and go into the ER a couple of times a year for your asthma. You might want to switch and think you're going to do better. It really, or you have another manifestation of EGPA, your skin disease pops up. So I think it's a good conversation. And you can usually go back. I'd like Dr. Gordon to answer this question because I think she's thought about this as well, and she can share some of her own experience.
Yeah, sure. So I was diagnosed in 2014 with EGPA. So I just had my 10-year anniversary, and 10 years ago, none of these drugs were approved for EGPA. So it's great that we have all these options. At the time, mepolizumab was in the clinical trial for the MIRRA study. And my doctor and I tried different medications like methotrexate, azathioprine, and they really weren't working for me to control my symptoms. So I was offered the opportunity to participate in the MIRRA study, and I did the clinical trial. And I've been taking mepolizumab for the last 8 years. And in combination with some other immunosuppressants, it's really helped me. I was on 20 mg of prednisone before starting the mepolizumab, and I got down to 10 mg per day. It's 8 years, and I'm still on 10 mg per day of prednisone, and I have some active disease and occasional flares. Now that the benralizumab's been approved, I've been talking with my doctors, and we decided that I should give it a try. We don't know whether it'll be better than the mepolizumab, but it could be. So I'm happy to say that I got my first delivery, and I'm about to take my first injection of benralizumab. So we'll see how it goes. But I just want to encourage patients to participate in the clinical trials because this is how we learn. And now we'll see in the real world, while both of these drugs are available, whether or not switching is helpful for some people or others. And interested to hear more from Dr. Merkel about how you make a decision whether to try the drug or not with one of your patients.
So whether you try the drug or whether you try the switch or both. So
Yes.
First of all, whether to switch or not, I want to remind you, it's a happy problem. We have 2 drugs that we think are effective. In rheumatology, we treat a variety of systemic immune-related diseases, autoimmune diseases like vasculitis, but other things. We have found that, for example, in rheumatoid arthritis, we have quite a number of different drugs. There are 5 different drugs that are anti-TNF. And for reasons that we're not sure, some patients respond to drug A, some to drug C, some to drug E, and some not at all. And so we do switching a lot. We do different things. So it's good to have options. So I think switching is reasonable. However, if you're always looking for perfection, it's hard. Trust me, it's hard to be perfect. And so you need to sort of what your goals of care are. And so you need to define those before. So if I'm going to switch, what am I looking to do? Obviously, perfect would be great, but what would be considered success? Try to define that before you start the drug so you can figure out whether you've achieved that. And you need to give it a couple of months to be on it to make sure you see what's going on. Are you asking, how do we decide to start mepolizumab versus benralizumab? Yeah, that's a tough one. So both good choices. One drug is 1 shot a month. One drug is 3 shots a month. I think I'm not the one that has to take the shots. I've given them, but I'm not. But some people find them annoying. Some people say, I don't care. I just want to get something that works. It's really up to you. On the other hand, one drug's been out for more years for EGPA. One drug's been out for shorter years. One drug seems to allow people to get off glucocorticoids a little better than the other one. Would be the benra. Is that a reason? The cost may be an issue depending on what your copay is. And here's something that you may not want to hear, but it's likely to be true, is your insurance company may make that decision for you first, which is which one to start, because they may have some sort of deal about what drug they can get for a certain price. So I think it's a happy conversation. We're only just beginning to have it. The drug was only just approved 2 months ago, benralizumab, so it's a new problem. And I think you have this discussion. Additionally, patients may already come on 100 milligrams of mepo, and then you'll say, well, why don't we increase that? So it's a nice problem to have. I'm not here to sell drugs per se. I think that they're both terrific. They're both helpful. I think we're going to be starting a lot of new people on benra because it's new and out, but it hasn't been around as long for EGPA. I want to emphasize, I think these drugs have been very safe. Why do I say that? Because that's good. And the fact that Dr. Gordon was on this drug for 8 years, I remember when she started it, tells you two things. One, it must be helping her, otherwise she wouldn't keep using it. And two, it must not be bothering her too much, otherwise you wouldn't keep using it. And so the balance of that is what's important. And so we tend not to stop these drugs because people seem to like them, they seem to help, and not bothering them a lot. So that's good. Now, I hope that a couple of years from now, we have another webinar, and our question is, okay, so who do you stop? That would be a great question. I love that question, but we don't stop them a lot yet until people are doing great. By the way, doing great is good. That's what we want.
Yeah, so there's a question in the chat about whether the drugs need to be taken for the rest of your life, and I think that gets to the point that we don't yet know that, but we hope to learn more about that as we go along.
Well, we hope that the rest of your life is a long time, and so that is an issue. This is a common problem in vasculitis now for many forms of vasculitis, which is that we have effective treatments, but the diseases tend to be relapsing diseases, and relapses suck. So you got to weigh being on drugs that change the immune system for a long period of time versus a risk. And so when to stop, when to reduce dose is a challenge that we're doing research in, and we're doing it carefully because it's a good question. It's an important question.
Can you also talk about the effect of these drugs on, say, asthma and nasal symptoms versus neuropathy and other organs?
Sure. Let's be clear. Almost all the published data we have relates to the use of these drugs, IL-5 blockers, for asthma, sinus disease, or nasal disease. There is no clear data on its use for neurologic disease, cardiac disease, or skin disease. That being said, I don't know if those manifestations of disease have completely different biology than the other stuff. I think it's very similar biology, but some would argue that maybe the airway disease is much more eosinophil driven than other parts, and that may be true. So we're looking at some of the data from the trials, and we're trying to figure out whether or not people were less likely to get the other manifestations when they're on the drug. The trouble is we screened people into the trial who were not having those diseases. Now, in the real world, if there is, wherever that is, that's why our VCRC registry is so important. We have patients over years. We're going to try to look, if you're on these drugs, are you less likely to get a recurrent neurologic disease or something else? There's a French group that's looking at trying to treat this earlier in the course of disease. Will it help prevent neuropathy? Will it treat it faster? These are, again, happy problems. I can tell you that at our center, we're pretty quick to start people on anti-IL-5 drugs, even early when they might have cardiac or neurologic disease. But we're usually doing that in addition to prednisone and maybe in addition to cyclophosphamide or rituximab. So how do you sort all that out? It's not that easy. I think there are ways, either trials or other ways to do it. But it's a good conversation to have with your doctor, and it's a good question.
Dr. Merkel, I just wanted to clarify with you, we're running out of time and we have quite a few questions left. Can you go
I can keep going. Let's keep going.
Okay, good. All right.
And you can edit out my lecture and just do the questions.
So I did want to say that Jen alluded to, or she encouraged people to do clinical trials. And there was a question in the box about that. It says, I've tried to join research group, I have EPA, but declined as I live in the UK. I've only taken Fasenra, but UK licensed for 8 weekly intervals and stopped now, and I'm on Tezepelumab offered rituximab. So two questions. Does rituximab have different dosages? And is there anything they can do if they live in the UK and they want to be in a
All right.
research?
There are about 12 questions in there that I can think of, but I will answer a few. Number one is, thanks for joining us here. It's not too late in the UK. So there are different dosing. Again, you don't want to be restricted by the asthma dosing and sort of time limit. I'm not sure I understand that. I can't discuss your individual situation there. But the Tezepelumab is a drug that's being used for asthma, eosinophilic asthma. It's being tested now in EGPA by a UK group, actually. So they're actually running a trial in the UK just for this drug. So we'll see whether or not that is useful. You asked about rituximab dosing. There are two different. Rituximab, when we use it, we tend to use it 1,000 milligrams times 2, or 375 milligrams per meter squared, which is based on weight times 4. Most of us are using the 2 dose. You use it once and then you think about it again in 6 months. So that's the general way of doing it. In terms of joining trials, so the MIRRA trial and the mepolizumab trial both had sites. We had sites in the United Kingdom, in England. We had sites all over Europe. We had sites in lots of places. So there are trials being done in the UK. The registry the VCRC registry that I mentioned, it's been mostly is the US and Canada, but we're expanding it to the UK and to Germany and to Italy, where hopefully in the next 2 months we'll have those open as well. And there are trials that happen all over. There aren't that many trials in EGPA. I'm helping to run another trial internationally with a different drug that's in addition to the IL-5, and I'm working with a company, and that's being done in a variety of countries, including UK and Europe and Japan. So, but we don't have a lot of trials. Now, one way to join a trial, we have an option, Dr. Gordon's going to tell you about, we have an option for being part of research for EGPA, no matter where you live. And maybe, Kathy, you can put up the last question.
Absolutely.
What a great tee-off. It was excellent.
Yes. Let's see. I'm sorry, give me just a second here. There we go.
Are you a member of the VPPRN, the Vasculitis Patient Powered Research Network?
All right. It looks like we're doing pretty well here. 80% have.
80% seems to be our turnout.
It does.
So it looks like the majority of patients are, or participants are in the VPPRN. Some of you are not, but a good number of you would like to know more. And one's not sure, but you can ask Christine Young, who is our network manager, and she'll be happy to tell you if you are. So Jen will tell you about this.
Yeah, so the VPPRN is an online registry. You can participate from anywhere in the world. You should be seeing a slide with a QR code. You can find more information about this the Vasculitis Foundation website or the VPPRN website, vpprn.org. And this is we have, I think, 500 people living with EGPA that are currently members of the VPPRN. So that's the largest group of people with EGPA in the world. And we are collecting information similar to the questions that we asked in the polls so that we can find out in the real world what people's experience are with vasculitis, with EGPA, with their symptoms, with their treatments, et cetera. And there's lots of really great information already available online about how people are living with EGPA. So if you're not a member and you said you were interested, I encourage you to go and sign up. And if you are, we have some new studies coming up soon in the new year. So hopefully you'll participate in those. Thank you.
Okay, I think we've had many questions. Dr. Merkel, do you want to add anything right there on the end?
Well, let me just take a quick peek.
There are quite a few questions, but a lot of them are specific to the individual's health, and we have said that you're not the doctor and you can't specifically answer questions. I wanted to just make sure we
I'm some people's doctor, but I can talk to them.
Correct.
So I think that hold A lot of them are sort of similar. We've answered some of these things. ANCA
Right.
positive versus ANCA negative is a great question. We just don't have enough data to be able to answer that question about whether if you're ANCA positive, you're better off or not on these drugs. But we're using them for patients who are both positive and negative for ANCA. And I think that a lot of it is about, should we be on it? That's a question that you should ask your doctor or provider directly, and say, I've heard about these. Should I be on them? Why yes, why no? Or go to an expert center if you feel that would be more helpful and learn more about it. It's not absolute yes or it's complicated. Treatment for autoimmune diseases are complicated. And it really depends on who you are, where you are in life, what other medical issues do you have, how important it would be beyond this, which manifestations do you have. But I can tell you that at this point, the majority of our patients with EGPA are on one of these drugs. And that's because they work. Have they cured it? No, but we'll get there, I hope. But let's treat well. Are they often on something else? Yes, that's okay. And I want to repeat something I made earlier. Patients who are doing the best with their asthma and their nasal disease, most of them are also taking inhalers in addition to the IL-5 drugs. That's important to remember. And, you don't want to stop everything at once. You want to get off the prednisone, you got to keep taking your inhalers, either nasal inhalers or bronchial inhalers or both. They're very effective. They have low degree of side effects, and they're an important part of treating the airway disease as well. Again, have those conversations. What should I be on? In what order do you do these? These are chronic diseases, so it may take some time to sort it out. But this is a happy problem. I want to thank the Vasculitis Foundation for hosting this and inviting me to be part of it. Again, this is your Vasculitis Foundation. Remember that. This is the time that many people make donations at the end of the year. Think about the Vasculitis Foundation, which serves you well. You should, I hope this was helpful. I want to thank people who have participated in our research and all the things we do. We can't do it without patients volunteering. We know that that's a big commitment often, but although for the VPPRN, it's a relatively small commitment. We're happy to have you. And I want to thank my partnership with Dr. Gordon, who's a wonderful partner in the Vasculitis Patient-Powered Research Network and many other things. So thank you all.
And thank you so much, Dr. Merkel and Dr. Gordon, for giving us your time today. So we do want to thank you. We appreciate all the information that you gave us, and the Vasculitis Foundation for hosting these educational webinars, seminars, and also for our sponsor, AstraZeneca. And thank you, everyone, for participating today.